Hi guys, I'm Sajad Pathan and welcome to the Frcem High Yield for the Intermediate SAQ. We'll move on to the fractures of the lower limb, and the most common fracture which we see is the fractured neck of femur. The reason it is important is it has to be expedited because it carries a long-term morbidity and mortality, and that is why, and these patient population or elderly population, they have to be treated early. Therefore, many hospitals do have a fast track in place. The importance of this thing from any perspective is pain control, ruling out the cause of the fall, and ruling out any acute abnormality or acute event happening. Like, we may just focus ourselves on the neck of femur fracture, however, the patient fell down because of a stroke, or a patient fell down because of angina or pulmonary edema. Secondly, the patient was fallen down for a long period of time. We will miss out rhabdomyolysis because of the prolonged lie. We'll miss out on serious bed sores, dehydration status. So as an A&E physician, I want to look at the other things apart from the pain management of the neck of femur fracture, because once I've controlled the pain by doing a fascial lecca block, the orthopedics can take care of it, but I have to rule out the other things. So an A to E assessment is mandatory. Distal neurovascular assessment of the lower limb is mandatory. Doing a fascial lecca block is mandatory. Doing an ECG, chest X-ray, and observation, a set of observation, just to rule out if there is nothing else going on. And you'll do a venous blood gas or an arterial blood gas based on the circumstances to rule out any other event going on. That's your cortical disruption at the neck of femur, and that's a fractured neck of femur on the right side. Okay. They don't ask for Gardner classification. They might ask you on fascial lecca block using the blind technique, so you should know what the blind anatomical landmarks are. You should know the ultrasound image of femoral nerve. Describe the abnormality in this X-ray.
Left
Neck of what?
neck of femur.
Left neck of femur cortical disruption.
Okay. So let me give you the scenario. This is a 14-year-old guy who's come with a limp. He has no other abnormality, no fever or any other systemic symptoms. There is no history of trauma. When you look at him, he's obese, and when you do an examination of his genitals, they are underdeveloped genitals. There is slipping of upper femoral epiphysis on the left side. So remember, 14 years old, obese, underdeveloped genitals, slipped epiphysis on the one side. The orthopedic surgeon will accept it for fixing it, but at the same time the orthopedic surgeon will ask for fixing on the other side as well, because if it has happened on one side, it will be happening on the other side as well. And sometimes it's just bilateral, it's just caught incidentally on the X-ray. If it is not seen on the X-ray, what view would you like to obtain?
Frog.
Frog view. Toddler's fracture, 5-year-old, unable to weight bear, was in the school, came with limp. Same like scaphoid fracture, fracture may not be seen, clinical suspicion of a spiral fracture. Then you put a long leg cast, X-ray after 10 days, fracture plan follow, no weight bearing. You may think as an NAI, but if there is no risk factors, then rule out the NAI by history and physical examination, past attendances, family structure. So you need to think about that. Less than 30 years of age, if it is young patient with sclerotic margin, it's benign, as long as the cortical disruption is not there. So here there is a cortical disruption. Here there is a cortical disruption. In osteomyelitis there might be cortical disruption. Most of the time, if there is no cortical disruption or it's not approaching the growth plate, then it's benign. Okay. So it is chondromas or cyst. You need to refer to orthopedics outpatient if it is not involving the cortical cortex or the growth plate. A swollen left knee joint. Differentials.
Hemophilias.
Hemophilia, lymphoma,
Lymphomas,
leukemia,
lymphomas.
bleeding tendency, von
Von
Willebrand
Willebrand.
disease,
Yeah.
trauma, if it's a young chap, non-accidental injury. Okay? You will see some blood collected over here. That's hemarthrosis of the joint. Okay. This is the most unfortunate person on the planet. He has an intraparenchymal bleed with midline shift. He has
SDH.
an epidural or extradural bleeding on the right side, a subdural bleeding
EDH.
on the left side.
EDH on the left.
Hmm? Yeah,
EDH.
this is extradural and this is subdural, sorry.
Yeah.
So subdural on the right and extradural on the left. So all three in one film. So how would you write? What are the abnormality on the CT scan? Lens shape opacity is seen on the left side, not crossing the fissure line. Crescent shape opacity is seen on the right side, likely
SDH.
subdural, not SDH or EDH, right full form. A circular opacity seen on the right frontal area with midline shift, likely intraparenchymal bleed. This bleeding is happening because of which vessel?
MCA.
No. The vessels which are attached to this thing. It does not.
It is an arterial bleeding, so it's middle meningeal artery.
MMA.
This one is a emissary veins or bridging veins. It's a venous bleeding. What is this sign called as?
Pneumocephalus.
Yes, that is pneumocranium. There is pneumocranium. What is this sign called as? Looks like a mountain.
Yes.
Mount Fuji sign. Okay. If you look here, normal CT scan, that's front, that's back, normal CT scan. If you look here, front, back, the white shadows along the suprasellar cistern and circummesencephalic, you can actually see the entire circle of Willis on the right side especially. So that's your subarachnoid hemorrhage. Sudden onset of headache, thunderclap, highest intensity within 1 hour. Traumatic is not that fatal than non-traumatic ones. Okay. Loss of lung marking on the right side and a collapsed lung on the right side. No mediastinal shift or maybe mild mediastinal shift. So you'll say airway trachea is central, that's not abnormality. Collapsed lung, loss of lung marking, diaphragm looks normal, cardiac shadow is normal, everything else looks okay. This is a pneumothorax on the right side. Similarly, there is a pneumothorax on the left side over here with mediastinal shift. So you have described the abnormality. Now they will say what is primary pneumothorax and what is secondary pneumothorax, and you need to know the algorithm given by BTS. When do you put a drain directly in a spontaneous pneumothorax?
It's life threatening.
Hemodynamically unstable or
The size is more than 2. That's not.
bilateral. Okay. Then you come down to define between primary versus secondary. If there is age more than 50, history of lung disease, smoker, then it becomes secondary. If it is none of these, then it's primary. Okay. Then there is an algorithm of 2 centimeter, more than 2 centimeter, less than 2 centimeter, aspirate, more than 2 centimeter, put a drain. All patients who have been drained will be admitted with oxygen. All patient who has been aspirated and discharged will be given discharge advice. What discharge advice will you give to this person apart from doing a repeat X-ray request at 6 weeks and a chest physician follow-up?
Not to go for
No
deep sea
deep sea.
diving, no flying.
So no deep sea diving throughout life?
No.
Yes.
Yes.
No flying until complete resolution of pneumothorax on radiological imaging. And normal, you might say, if symptoms worsens, please return to the A&E. Yes? So we tend to forget the simple things. Now describe the abnormality. It's a very ugly X-ray, but it's the same one which we had done in the past. This is an alcoholic who was lying down. Police brought him. He's been soaked in vomitus. The lung markings are not clear. However, I could see a shadow over here around the heart, which is pneumomediastinum, and I see air in the skin, and it is Boerhaave syndrome. C-spine. C2 over C3 is subluxated normally in less than 8 years of age in more than 50% people. Okay, so that's not an abnormality, that's normal. That's called a pseudo subluxation. Or C3 over C4. Diagnosis.
Coffee beans.
Diagnosis is sigmoid volvulus.
Sigmoid volvulus. Again, this could be a sigmoid volvulus as well. So, coffee bean sign is correct. What is the management? You,
Laparoscopy.
Decompression.
Laparoscopy. I mean, surgically intervene.
so, will you do it?
No.
No.
Refer to the surgeon.
Refer to surgeons. They didn't say what is the definitive treatment. If definitive treatment is asked, surgical exploration. However, A&E management is keep patient NPO or nil by mouth, nasogastric tube insertion, IV fluids, normal saline 500 or a liter over 2 to 3 hours, antiemetic, ondansetron 4 milligrams, isn't it? Paracetamol 1 gram IV. Refer to surgeons. This is the management. This is the mistake you guys do. You write, you don't read the question properly and write, okay, surgical exploration. You're not going to do that. They'll say, what is the ED management? ED management process. If I ask you, what is the bedside test you would do in this patient? Or in any patient, bedside test. Venous blood gas, urinalysis, ECG, portable chest X-ray, these are bedside tests. Echo is not bedside test unless patient is really unstable and you want an emergent echo. A chest X-ray is not bedside test. So you need to remember those things. Loops of bowel seen in a step ladder pattern, air fluid level seen over here with a radio opaque foreign body, which could be an artifact. Okay. Is this large bowel or small bowel?
Small bowel.
Difference between large and small bowel based on the X-rays.
Austria is seen in large bowel. Valvular congenitals is seen in small bowel.
And
This is
small bowel is in the center.
Central is small
Large bowel
bowel.
is on the periphery. Okay. For intestines to be obstructed, what is the length or what is the diameter it should be dilated?
14.
Have you heard about 369 rule? Small bowel more than 3 centimeter dilated in diameter, large bowel more than 6 centimeter dilated in diameter, and ileum or cecum more than 9 centimeter diameter. Okay, that's obstruction. Okay. Let's move on to something which we see very commonly in the department. What is your diagnosis based on the image?
Can be cellulitis.
So it is flexor tenosynovitis. It's a flexor tenosynovitis. The flexor tendon sheath, if you remember your primary,
Yeah.
flexor tendon sheath encloses the flexor tendon,
Except for this.
except for this one
Yeah.
becomes the ulnar bursa,
Uh,
and this one becomes the radial bursa. And that is the reason you do finger stick over here, so that if infection happens, it will just extend up to here. So this is a flexor tendon sheath infection or inflammation, and what the examiner likes to ask would be, what is cannibal sign? Finger held in partial flexion.
Okay.
Sausage shaped swollen digit. Pain on passive extension. And there is one more. Fusiform swelling or something. What's the diagnosis?
I said it's
What color child is this?
Dark.
dark.
Dark color, likely African, right? What disease do they have?
Lymphedema. I mean, this is operative Bancroft type.
Think common. Think common. What disease do they suffer from?
Malnutrition.
Okay, malnutrition, that's fine.
Kwashiorkor.
That's fine. What's a hematological condition?
Sickle cell anemia.
They have sickle cell, right?
Yeah.
This is dactylitis. If you
Oh.
look at closely, it is pencil shaped digit. That's dactylitis in sickle cell. This is sickle cell crisis. Five-year-old with bruises, causes.
MAI.
Non-accidental injury and accidental trauma.
Accidental trauma.
Okay.
Mhm.
Then, but it doesn't look like multiple age of bruising. What else?
Parents beating the child.
No, our friends. That is, parents beating is
Oh,
non-accidental injury.
lymphoma leukemia.
Lymphoma, leukemia, coagulopathy.
Coagulopathy.
Very common. You see here
Yeah. Neck fash.
that this is necrotizing fasciitis, piperacillin tazobactam plus clindamycin, surgical referral. Air seen in the subcutaneous tissue. Organism,
Clostridium perfringens.
polymicrobial.
Polymicrobial.
Air around the perineum. What underlying disease does this patient suffer from?
This is Fournier's.
Fournier's gangrene.
This is Fournier's gangrene. What is the underlying condition this patient suffers from? Who gets Fournier gangrene?
Diabetic.
Diabetics, yes. Diabetics or immunocompromised.
Immunocompromised.
Yeah. Again, surgical referral, piperacillin tazobactam, polymicrobial, surgical debridement. What are the causes of large for gestational age?
Polyhydramnios. Polyhydramnios.
What is the most common cause of large for gestational age? And I bet you will not come to the answer even if I stay here till evening.
Large baby. Misdiagnosed age.
Absolutely.
Oh,
Females cannot remember dates. Female cannot remember date. You guys must have come across, you ask them, what was your LMP? And next thing is they either look to their parents or open their mobile phone. that is miscalculated date is the most common cause of large for gestational age. Then comes your polypregnancy, polyhydramnios, whatever, hydatidiform mole. Okay, what is that?
Placenta.
That's your hydatidiform mole.
Oh.
Okay. Dislodgement of the humeral head on the right side from the glenoid cavity. Right? Dislodgement of humeral head on the right side from the glenoid cavity. This looks like a posterior shoulder dislocation. This is an anterior shoulder dislocation. You should know the names of the manuals.
Teardrop sign.
Teardrop sign, effusion in the left maxillary sinus. The elephant looks okay. I don't see any eyebrows. Yeah, there is an eyebrow here.
There
You
is.
see?
Yeah.
There is an eyebrow sign over there. The elephant looks fine. You see the elephant now?
Yes.
Now you can trace the elephant in that one. So this is the ear of the elephant. This is the trunk. You need to shape it. Ear. This is the trunk. That's the ear. Diagnosis.
Orbital cellulitis.
Okay. From exam point of view, this is orbital cellulitis. Okay? Anybody who comes with a swollen eyelid is not nephrotic syndrome, periorbital cellulitis, it is orbital cellulitis from exam perspective. And the question is, how would you clinically differentiate between periorbital versus orbital cellulitis?
Ophthalmoplegia,
In
orbital cellulitis,
good, ophthalmoplegia in orbital cellulitis and
visual pain, will be having pain
yeah,
in orbital cellulitis,
reduced vision.
reduced vision,
Yep, good. So reduced vision or visual acuity is reduced in orbital cellulitis versus preceptal. It may be intact. Ophthalmoplegia and painful eye movements. Okay. What do you see?
This is the eye fundus.
This is the fundus of the eye. You see the cup or the fundus, and you see a macula, which is looking like a cherry red macula. Do you see the pale optic disc? The optic disc looks pale. The disc looks pale and cherry red macula. Where am I going to?
This is
This is central
ERA.
retinal arterial occlusion. Okay? CRAO, central retinal arterial occlusion. Okay? Okay. Painful, painless, loss of vision.
painless.
Painless, good. Treatment.
Anticoagulants. No, this thing. Drop.
Categoral? No.
No. The other one, the other drop.
Okay. So, this is global massage, topical GTM, acetazolamide,
Oh.
mannitol. Okay. Global massage, topical GTN or oral GTN. It's global massage, oral GTN, acetazolamide and mannitol. Okay. What is this?
Sunset.
This is
That
a
is-
sunset, and this is a very stormy sunset. That's your stormy sunset. Stormy sunset appearance of the fundus with tortuous veins, flame-shaped hemorrhages, cotton wool spots,
CRVO.
central retinal venous
Venous
occlusion, painless loss of vision. Treat the underlying cause. Okay. Risk factors: hypertension, diabetes, ischemic heart disease. painful loss of vision with headache with vomiting, painful loss of vision, headache with vomiting, mid-dilated pupil, cloudy cornea, came from a theatre hall where it was dark and suddenly got mid-dilated pupil, painful loss of vision, vomiting, abdominal pain, cloudy cornea. Treatment.
Close angle glaucoma.
Pilocarpine, timolol, astazolamide, oral plus IV, mannitol. Refer urgent to ophthalmologist. What is this?
Retinal hemorrhage.
So this is pigmented spicules. I'm sorry for the poor image quality. Let me just take it. These are pigmented spicules seen on the periphery. It is retinitis pigmentosa. They like to ask the associated syndromes. Usher syndrome, Frcem's disease, A beta lipoproteinemia. So just go through it, remember it, finish the exam, forget it. Okay, what is this?
This is
Glaucoma.
no. It's seen with a dye.
So you have put fluorescein dye and you see this pattern,
This is
a
a
lacy pattern.
foreign body.
That is
The waterfall sign.
herpes,
Oh.
Oh,
dendritic
dendritic ulcers.
ulcer. That's dendritic ulcer. When you see a green color lace in the eye with a blue light, it is dendritic ulcer. Acyclovir orally, acyclovir topically. Refer to ophthalmologist urgently. Okay. What is this? So there is a tear in the cornea because when I put the fluorescein dye, it seeps inside and is accumulated in the anterior chamber. So corneal tear or antechamber perforation.
Keratitis.
This is antechamber perforation. Corneal tear, antechamber perforation. That test is called as Siedel's test.
Yes.
What is this?
Injunctival hemorrhage.
Scleritis.
Absolutely. Have you ever eaten custard apple?
Yeah.
Yeah. How it looks? White with some black spots coming from inside, isn't it? So those seeds look, you can see it through the white part. Similarly, you see those black parts coming. So that's your scleritis. This patient suffers from HLA-B27, ankylosing spondylitis, Behcet syndrome. Okay, scleritis, and that is your uveitis because there is an irregular cornea. Let's go to some ECGs now. Should we take a break? Okay, describe the abnormality on the ECG.
V1, V2. V1, V2.
So,
Rate rhythm.
Oh, rate rhythm, sorry. Okay.
rate, normal, rhythm, normal, axis, normal, P waves present a normal, QRS looks normal, ST segment, ST segment, ST segment. There is a depressed ST segment in 3, AVF 2. There is an ST segment elevation with downsloping coving with biphasic T waves in V1, V2. What is the diagnosis?
Brugada syndrome.
This is Brugada syndrome. Channelopathy, sodium channels. Okay, so you need to take family history of sudden cardiac death, less than 40 years of age. What treatment this patient needs to get?
Ablation.
You fit in with an automated implantable cardioverter defibrillator. Okay? Here, there is no ST segment elevation, but you see biphasic T waves in V2, V3, V4, V5, but classically it is seen here V2, V3. This is Wellen syndrome or anteroseptal infarct. proximal LAD or left main disease, goes for PCR. Rate, normal. Rhythm, normal. Axis, left axis deviation. Left axis deviation. Okay. P waves,
Present.
prolonged QR, right?
Prolonged
PR.
PR.
Prolonged PR. So first degree heart block.
Heart block.
Okay. So we got left axis deviation, first degree heart block. QRS looks like RBBB. So RBBB with right axis deviation is normal. RBBB with left axis deviation is not normal. Same way, LBBB with
left.
right axis deviation will be abnormal. Okay, so I got three problems here. Right bundle branch block with first degree heart block with left axis deviation. These are the three abnormalities in the ECG, and when there are three problems, it is called as trifascicular block. Okay, this patient will go in asystole if not treated. This patient needs a permanent pacemaker. If you would have just tried to search for MI or this, you would have not got it. If you search P waves, rate, rhythm, then you will find it. Rate, bradycardia. Rhythm, sinus, so P waves are present. Okay. Axis, right axis. Then P waves. P waves are present. If I put with a piece of paper, they are regular, but not all P waves are followed by QRS. And QRS duration is also regular. This is a complete heart block. Yeah? One of the features which will put patient at the risk of asystole.
Torsade de Pontis.
So, polymorphic, ventricular tachycardia, torsades de Pontis, magnesium, if patient is arrested, defibrillation, and once the patient, you give magnesium, ECG becomes normal, what abnormality will you see in the ECG? What precipitates torsades?
Sinus.
Long QT. Long QT precipitates torsades, and what are the drugs that precipitates long QT?
ABCD.
So antiarrhythmics, antibiotics like macrolides and quinolones, antipsychotics, antidepressants, and antiemetic, etc. Okay. So, and then there are congenital long QT syndrome called as Romano-Ward and Javel-Lange-Nielsen syndrome. Romano-Ward is autosomal dominant. Javel-Lange-Nielsen is autosomal recessive, but it comes with deafness. Rate, normal. Looks like bradycardia. Bradycardia. Yeah. Rhythm. Where is P waves?
There are P waves.
Axis, you can't comment. P waves are present. QRS looks okay. QT looks prolonged, isn't it?
Yes.
QT looks prolonged.
Long QT.
So if you have to calculate based on the RR interval with the Bassett's formula, QTC. So prolonged QT syndrome. This is antiarrhythmic, antibiotic, antipsychotics, antidepressants, antiemetics. Romano-Ward is autosomal dominant, Javel-Lange-Nielsen is autosomal recessive with deafness, Bassett formula, and QT puts risk of torsades and ventricular fibrillation.
Regular.
So rate is normal, rhythm is regular, P waves axis you can't comment, it looks like right axis. P waves are there, QRS looks okay. ST segment elevation in 2, 3 VF, even in V1, V2, V3, V4, V5.
Global.
This looks like tombstones. So there's a global infarct. Had it just been a right-sided infarct, what additional leads, or had it just been inferior wall infarct, what additional leads would you want to take?
The posterior.
So you want to take V7, V8, V9, and right side it leads.
Right side.
Sepsis bundle is now become 1 hour bundle. If you go on surviving sepsis, it is changed to 1 hour bundle, and basically it's just the same stuff. Measure lactate, take blood culture, give antibiotic, fluid resuscitation. If patient does not respond to fluid resuscitation or lactate still remains high, use vasopressors. This has become 1 hour bundle. Who can give consent?
Age more than 18.
Anybody who's more than 16 in the UK, or if patient is less than 16, they should be
Accompanied by another.
Gillick competent. There is something called as Gillick competent. So if they are Gillick competent, they can give consent, especially for high risk behaviors like sexual activities. And a person having lasting power of attorney can give consent on behalf of adult patient once capacity is lost. If age is less than 16, then a person with parental responsibility can give consent. So who has parental responsibility? Mother. When can father have parental responsibility?
If they're living together.
They staying together?
If they are married to the mother, or the name appears on the birth certificate. Married to the child's mother or listed on the birth certificate. When do you break confidentiality?
Yeah.
When is
3 broad reasons. With
consent.
patient's consent.
The
In
risk.
In
public
the,
interest.
Public interest.
When required by law.
No.
Simple. These words you have to write. VAP bundle. That's ventilator associated pneumonia bundle. How do you reduce ventilator associated pneumonia? By keeping the patient's bed raised, it will prevent microaspiration, because when you are sleeping, you will have microaspiration as well. So it will prevent microaspiration. If you do oral care with chlorhexidine or just brushing the teeth, will prevent microaspiration. Subglottic aspiration through the tube or oral aspiration, suction, that will reduce microaspiration. 3 things. Head and up, subglottic aspiration, dental hygiene, prevents microaspiration. Then peptic ulcer prophylaxis will reduce the length of stay. Venous thromboembolism prophylaxis reduces length of stay. Daily sedation hold and assessment to extubate reduces length of stay. I can ask this question as give 6 points of VAP bundle, or I can say give 3 points of VAP bundle which reduces microaspiration, give 3 points of VAP bundle which reduces length of stay.
Oh.
So you need to know.
Daily sedation.
We will stop over here and we will come back in the last session of high yield concept.